Today we have Anjali. Her favorite subject is oral surgery, and Anjali is going to give us a very short overview of extractions. So, like what equipment to use, how to look at the X-rays, and what type of consent. What you discuss in consents? Yeah.
Okay, pleasure. So the first thing with patients when they're coming for extractions is preempting any potential issues and having a really good plan in place. So the first thing we always want to look at is, as well as looking at the patient themselves, having a good look at their X-rays. This is a patient that we've just seen this morning, and there are things to look at where teeth are very broken down, for example, this tooth here, and we want to think about having a plan A for how to take the tooth out. If that's to fail, then what would be your plan B? And then even a plan C, so that there's no point where there isn't any point where you get completely stuck and don't know what to do.
So I think in that you mean that you want your nurse to be prepared, have all the equipment ready, and be prepared for surgical as well.
That's it. So we want to have the correct instruments in terms of, this is an upper left six, so the correct forceps, the right side, upper obviously, having a range of luxators and cryos, Warwick James, all the different elevators that you think you might need, and then having also ready your plan B. So if we are to do a surgical, have the motor ready, have the
burrs ready,
the sutures ready, because the last thing you want to do is halfway through stop and start setting up with your motor, because not only does it waste a lot of time, but it doesn't feel great for the patient.
And the anaesthetic wears off.
The anaesthetic wears off, and also they feel like something's gone wrong, it's not planned. Whereas if everything is ready, if you don't need it, worst case scenario is you don't need it.
True. And also, I think important thing is to make sure that you have, in the consent, you actually tell your patients that you may need to do surgical and you might need to put stitches in.
I consent for everything, and again, worst case is that you don't end up doing these things, and in fact it's managing their expectations, so at that point they feel great that you've managed to avoid all of those things that you've warned them about. If you do need to do it, they knew about it, so consent.
Don't you find that when you're all set up for surgical, it never becomes a surgical?
It's always the way.
And then when you're not set up, it's always like, oh my god, rushing around trying to.
Absolutely.
So Anjali, can you just run through all the equipment? Then normally do you always start with luxators to break the periodontal ligaments?
Yeah, I personally exactly do that. So starting off with luxators, we've got a good range here as well, but depending on the tooth and how much is left, I will tend to go for a smaller one to start with and work my way around the tooth surface to exactly break the periodontal ligament and get a bit of mobility. Only when the tooth is showing mobility will I then apply my forceps. So just making sure to always apply apical pressure and being careful not to break the tooth. So very, very slow, steady movements to get the teeth out. And I often change between the two. Okay. So I'll luxate, maybe try a bit of the forceps movement, go back to the luxator.
What would you, like for instance, this upper six?
Yes.
Would you have gone straight for sectioning the tooth?
In this case,
first?
I did. Yeah. So what I did do is I did apply the luxator just to see if there were any movement. This tooth had been broken down for quite some time. So when we look at our radiograph, we can look at the bone levels. They're really good, which means where there's not been bone loss, the tooth, I didn't expect it to be mobile. There's not a large area of infection or radiolucency at the apex, which again means the tooth was solid. And this patient had, for various reasons, left this tooth like this for many, many years. So I tried a luxator for about 5 seconds, realised there was no movement, and then yes, I went straight in and sectioned it in the typical, what you may know as like the Mercedes-Benz shape.
Okay.
So
I've never heard of that before.
Got a pen? Yeah. So if you're looking at the tooth from the occlusal view, so you've got your fissure pattern like this. You know your mesiobuccal root is here, your distobuccal root is here, and your palatal root is here. So when you are sectioning, that's the shape you want to go for. So some people call it the Mercedes-Benz.
That's a very clever idea.
And then it's just really important making sure that you've got the right angle with your burr. So looking at have the X-ray up when you're doing the extraction, and have your burr at the correct angle so that you can make sure that you are splitting the roots right down the middle. The worst thing you can do is section an upper six in the wrong way, because then you're stuck with bits of tooth breaking off and the apices of the roots which you can't get to. So sectioning your tooth is really important to get the right angles.
So are these the type of birds you use?
So
these are fisher birds.
I would recommend everyone to have a fisher burr and a round burr. So fisher burr would be for, in fact our one has just gone through the autoclave, but it's slightly longer than this. And a round burr, if you are doing any buccal bone removal, personally I just use a fisher burr for everything because it's quite conservative.
And lots of water irrigation.
Has to be, yes, saline irrigation the whole way through, keep it nice and sterile. And we need to be using these surgical motors to prevent emphysema. You can't be using your fast handpiece from the...
No, that's a very good tip, guys. Do not use straight your handpieces, exactly, because it can cause emphysema. After you've removed the tooth, obviously, what do you do? I mean, if there's any granulation tissue.
Yeah, so Mitchell's trimmer is great to just scoop out any granulation tissue. Just be aware of any important structures.
Okay.
So in this case, we were quite far away from the sinus, but I wouldn't be digging around if it was close. Similarly, with a lower tooth, be careful of any nerve structures that are there. But yes, dig.
Okay.
I don't use that for every tooth, only if there's been quite a large area of pathology or granulation tissue.
Okay.
Irrigate with saline, and then only suturing really if you've raised a flap or if there's been a tear that you didn't mean to cause. But otherwise, I don't suture for every.
It's only if you've raised a flap, you suture, or if the flap's a bit loose or mobile.
Exactly.
And then, what post-op instructions would you give the patient?
Okay, so this is important. So one thing I always do is give the post-op instructions after the tooth is out, which sounds obvious, but often for time purposes, I know dentists who will give the instructions while the patient is going numb and you haven't got anything to do. Often patients are so nervous that they're not taking it in.
True.
So I'll always give my post-op instructions after because you can see they're completely relieved and then they're ready to listen.
Yeah.
So we talk about not rinsing for the first day. We don't want any of that nice the socket to
the clot to
dislodge. Exactly. Okay. So no rinsing for the first day. Rinsing with salty mouthwash for 7 days from that second day onwards. Painkillers, depending on their medical history, if they're able to take, I always recommend ibuprofen if they can take it. And I tell my patients to take it as soon as they get home.
Yeah.
That way it starts working before the numbness is worn off. We talk about avoiding biting lips, cheeks, burning themselves, smoking the biggest no-no. And I think patients who do smoke find that advice quite hard to take on board. So I'll always sympathise and explain that I know that it's hard to not smoke. Go to the pharmacy, get some nicotine patches, actively do something to help yourself not
or maybe
smoke.
even a few days before the extraction, they could actually do that. And then to start the salt water the following day. Maybe. Yeah. And then also one good thing we do in our practice is that we give a courtesy call to the patient, which is really good because then we know if the patient feels supported.
Yes, absolutely. That's one of the best touches to do, and I recommend everyone to do that. Whether this is, it just helps them feel that they've. It just completes the whole care that they've had and. Any issues.
I think Angela explained things really clearly. I think one other thing I will just add is that because Angela gets mainly referrals for extractions, but she's very careful. She looks at the X-ray. So what I'm trying to say is that if you do get a patient referred to you for an extraction, don't just take it that you're going to do that. Obviously do all your assessments yourself, check the X-ray yourself, check the symptoms yourself, just to make sure it's the right thing for the patient. Please don't go blindly and just take the tooth out, because there may be other options like root canal treatment, which you could potentially save the tooth. And maybe the previous dentist overseen that or forgot to mention it, or even if they did, then you're trying to get consent. So it's good to explain options, isn't it?
Well, as part of my, exactly as you said, I get seeing these patients as referrals, so I've never met them before or seen them before. Yeah. And I still end up talking to them about are you aware of options of root canal treatment if it's applicable, and
obviously if it's restorable.
Yeah. And I will also talk before we start anything as part of the consent, talk about if they're aware of the space afterwards, what their options are.
Yeah, that's
because
actually
the worst thing you can do is take the tooth out and then they maybe can't afford an implant, don't want a denture, and a bridge isn't suitable. Yeah. And then actually your consent becomes invalid because they would never have taken the tooth out if they'd known.
And actually that's again another good point Angela just made, because if a patient is deciding to go for an implant, then obviously the extraction has to be as atraumatic as possible to preserve bone. And sometimes we can do socket preservation by grafting the socket straight away, so cleaning it and grafting it straight away, and that way the patient will build up bone in 4 months, and then maybe they can have an implant then. Is there anything else you'd like to add to this?
You've covered most of the points, to be honest. I think the main thing I will always reinforce is the planning side of things. I think it's always, you can say it's that phrase, a stitch in nine saves time. No pun intended, but it really is. If you've got a plan A, B, and C, that's all you need. And it's really important to know when to refer to an oral surgeon and when to do it yourself. So it's just finding that balance between don't be a hero and at the same time don't be scared. It's good to try, and if you've got someone who can support you at work, go for it, give it a try. As long as you've planned it and assessed it, give it a shot.
Very good point, Anjali. Thank you very much. Thank you.